Hello friends and learners, welcome to Indian Medico. We have already discussed about hormone classification and their receptor and mechanism. Today we are going to discuss about anterior pituitary hormones and little bit about pituitary gland and its relation and development. I am very sorry about the noise, but I think you guys can listen to me clearly. So let's discuss about the topic. First I am going to tell about the relation of pituitary gland. Pituitary gland is situated in the hypophyseal fossa in sella turcica, which is surrounded by sphenoid bone and sphenoid sinus. These are sphenoid sinus, this air pockets and nothing but sphenoid sinus. And lateral to this sphenoid sinus there is another structure, venous structure, which is called cavernous sinus. And above the pituitary gland there is one structure which is called optic chiasma. And the connection between the pituitary and hypothalamus there is infundibulum or pituitary stalk. This is hypothalamus. And above hypothalamus we have third ventricle. So what are the relation of superior relation of pituitary glands? First optic chiasma, infundibulum, hypothalamus and third ventricle subsequently. And lateral relation of pituitary gland is sphenoid bone and sphenoid sinus with cavernous sinus. Inside the cavernous sinus there are certain structures like internal carotid artery, third cranial nerve or oculomotor nerve, fourth cranial nerve or trochlear nerve, sixth cranial nerve or abducens nerve. And there are two structure also, nervous structure like V1 and V2. V1 is fifth cranial nerve first branch, which is known as ophthalmic branch, and this is branch of trigeminal nerve, which is maxillary nerve. And the inferior relation is by the sphenoid bone or sphenoid sinus. Below this we have nasopharynx. In the hypothalamus we have two type of cell bodies. One is supraoptic or preoptic, another is paraventricular. This cell body sends their axon to the posterior pituitary gland. We have posterior pituitary, intermediate pituitary portion and anterior pituitary. Major hormone of the pituitary gland is secreted from the anterior pituitary, but there are two hormones which is secreted from the posterior pituitary, and those two are vasopressin, which is secreted from the paraventricular. This paraventricular nucleus is also known as supraoptic because this is above the optic chiasma, so this is known as paraventricular nucleus or supraoptic nucleus. This supraoptic nucleus secretes vasopressin. Vasopressin, another name is antidiuretic hormone or arginine vasopressin protein or arginine vasopressin. And the preoptic nucleus secretes oxytocin. Paraventricular, V for vasopressin, preoptic, O for oxytocin. You can remember by this. Those hormones are synthesized inside those nucleus and they will go through the axon till the axon terminal and they will be stored here. Whenever there is stimulus for secretion of this oxytocin and vasopressin, there will be secretion of these two hormones. Now let's discuss about the development of pituitary gland. We have seen that posterior pituitary is nothing but the extension of hypothalamus. So development of posterior pituitary should be from the hypothalamus. So there is downgrowth of posterior pituitary. And anterior pituitary is actually developed from a diverticulum which arises from neuroectoderm derivative. This neuroectoderm derivative, this is ectoderm, so this will be present outside the sphenoid bone or below the sphenoid bone around the nasopharynx, and they will migrate through a midline defect which is actually present during embryonal development. After the development completes, it will close. This defect will be closed. Till that time, this neuroectodermal diverticulum will reach the anterior pituitary area and it will completely develop anterior pituitary gland. So these two, like downgrowth of hypothalamic cell and upgrowth of neuroectodermal diverticulum will form the pituitary gland completely, and between them the intermediate portion remains intact till death. And this neuroectodermal pouch or diverticulum is also known as Rathke's pouch. Rathke's pouch. Now let's discuss about some clinical importance regarding anatomy. This posterior pituitary gland contains a lot of vesicles. This vesicle leads to formation of a bright spot during MRI, and particularly in T1 phase. So if there is bright spot in the posterior pituitary area, then that patient will be normal. If there is no bright spot, so there may be compression of stalk or defect in the posterior pituitary, or there is defect in hypothalamic cells. And another implication of clinical importance, if there is any adenoma or tumor in the pituitary glands, let's say growth hormone producing somatotrophs cell forms an adenoma. This adenoma will enlarge in size, and this enlargement will compress the other hormone producing cells like lactotroph, thyrotroph, corticotroph. Those cells will be compressed, and there will be deficiency of these hormones. This is hormonal effect. Another type of hormonal effect may be seen if there is tumor in the upper portion of anterior pituitary. It will compress the stalk, and after compression of stalk, like stalk compression, there will be decreased circulation of hypothalamic hormone to pituitary gland. Hypothalamic hormones, and most of the hypothalamic hormone is actually inhibitory in nature, except we know that prolactin inhibiting factor. So if there is any adenoma which compressing the stalk, that will lead to decreased production and decreased communication between the hypothalamic hormone, like portal system will be defective from the hypothalamus to pituitary, and there will be relative decreased hormonal concentration in the pituitary blood vessels. There will be less stimulation, there will be less production of all 6 hormones. No, actually all 5 hormones: growth hormone, TSH, ACTH, FSH and LH. But due to deficiency of prolactin inhibiting factor in the pituitary blood vessels, there will be increased production of prolactin. So if there is any adenoma and there is deficiency of these hormones also, then we can suspect that adenoma is compressing the stalk. And if there is any adenoma like somatotrophic adenoma, then growth hormone will be more but other hormone will be less. Another effect of compression due to adenoma is compression over optic chiasma, and we all know that optic chiasma compression, if it is from the center, then it will produce bitemporal hemianopia. And due to increased mass in the cranial cavity, will lead to increased intracranial tension. Now let's discuss about the hormones. I have discussed about this table. These are hypothalamic hormones. Growth hormone releasing factor will stimulate growth hormone release from pituitary. This will stimulate liver to produce insulin like growth factor 1. Somatotropin releasing inhibiting factor or somatostatin will inhibit growth hormone release from pituitary. Gonadotropin releasing hormone will stimulate release of gonadotropes. This LH and FSH. LH and FSH are nothing but gonadotropes. They will stimulate testicular cells and ovarian cells for sexual development and menstruation in female. Thyrotrop releasing hormone will stimulate to release TSH, thyroid stimulating hormone, from pituitary, anterior pituitary, and prolactin also. This TSH will stimulate thyroid gland to produce tetrahydrothyronin, tetrahydrothyroxine or thyronin, and triiodothyroxine. And prolactin will stimulate mammary glands in female to produce milk. And this milk production will be ejected by help of oxytocin. And this oxytocin secreted from preoptic nucleus in hypothalamus. Corticotropic releasing factor will stimulate anterior pituitary to produce ACTH. This ACTH will stimulate adrenal gland to produce cortisols. Prolactin inhibiting hormone is nothing but dopamine, and this dopamine will inhibit prolactin release from anterior pituitary, and low prolactin will decrease production of milk in female breast. Here is another diagram. I have taken this diagram from Ganong. Here you can understand one by one. One hormone is gonadotrop releasing hormone, which will go to anterior pituitary and will help to release LH and FSH. Another is corticotrop releasing hormone. It will also go to anterior pituitary and will stimulate to produce ACTH. Another is thyrotrop releasing hormone. It will also go to anterior pituitary and will help to release TSH. And here is dopamine. Dopamine will go to anterior pituitary and it will inhibit production of prolactin. Growth hormone releasing hormone will go to anterior pituitary, will stimulate production of growth hormone. And somatostatin or growth hormone inhibiting factor, it will inhibit production of growth hormone. And here is two hormone or cell body. One is preoptic which secretes oxytocin, and paraventricular which secretes vasopressin, and they will go to the posterior pituitary. They will be stored here and will subsequently released. And there's all hormones except the posterior pituitary hormones. Those all hormones like gonadotrop releasing hormone, corticotrop releasing hormone, thyrotrop releasing hormone, dopamine, somatostatin, and growth hormone releasing hormone, they will go to anterior pituitary via the portal venous system. There is venous circulation. Arteries will give blood supply to hypothalamus. There is venous return from the hypothalamus. This venous blood will go to the pituitary glands. As they contain the most of the hormone from the hypothalamus, they will stimulate mostly or inhibit mostly anterior pituitaries by venous circulation from the hypothalamus. This is one type of portal system. Portal system is nothing but venous blood from one organ is going to another organ. Artery is giving blood supply to first organ, and venous return from the first organ will go to the second organ. What are the examples of this portal system? One is pituitary. Another is, we know that, portal system, portal venous system, which is collecting bloods from the GI tracts, and they will go through the liver to the inferior vena cava via hepatic vein and portal vein. And the last one is in kidney. Inside kidney, we know that we have glomerulus, collecting duct and other ductules. From the glomerulus, there is efferent arteriole and afferent arteriole. Afferent arteriole will give blood supply to glomerular cells, and this glomerular cells, after giving blood to this glomerular cell, efferent arteriole will go towards the Henle's loop, and they will give blood supply to Henle's loop also. So arteries coming inside the first organ, and they are returning from the first organ and giving blood to a second organ. This is another type of portal system. So there are three organs which have portal system. One is pituitary and hypothalamus, another is portal system like GI tract and liver, another is kidney from glomerulus to Henle loop. Now let's discuss about the individual hormones. The first hormone is growth hormone. Growth hormone is secreted by somatotroph cells. These somatotroph cells will secrete growth hormone, which will be stimulated by growth hormone releasing hormone from the hypothalamus. This growth hormone will act via JAK-STAT mechanism. I have discussed about that in previous videos. JAK is the receptor, genus kinase, and STAT is the regulatory protein for growth hormone receptor, growth hormone receptor element, or somatotroph elements which is present inside the gene. What are the functions of growth hormone? Growth hormone will act for protein anabolism, carbohydrate metabolism. They will break carbohydrate and increase blood glucose level. And a high glucose level ultimately leads to decreased insulin sensitivity. It will also act on lipid metabolism, which will lead to increased free fatty acid. You can understand that high glucose level and high free fatty acid is nothing but the energy source for development and growth. And this protein anabolism, or storing of protein in different forms of structural proteins, will lead to growth, like growth of epiphysis, growth of different organs, etc. One major mechanism of growth hormone is via somatomandins. These somatomandins actually synthesized inside the liver. Growth hormone will act via growth hormone receptor in hepatocytes. From the hepatocyte, there will be increased release of insulin like growth factor 1, 2, somatomandin C, somatomandin C. They will finally act on different organ for their developments. These IGFs are nothing but insulin-like structures. We have insulin hormone, which has actually 3 chains. One is A chain, another is B chain, another is C chain. This A and B will persist and C will be cut off. But here, in case of insulin like growth factor, this A chain will extend and will have a D portion of A chain, and the C chain will not be cut off. So there is A, B, C and another D chain. This whole structure is IGF 1-2 like structures. There are certain clinical importance also regarding growth hormones. First is excess growth hormone. Excess growth hormone will lead to manifestation of 2 diseases. One is gigantism. Gigantism is tall statured patient which actually occurs if there is no epiphyseal fusion during excess growth hormone release. And another one is acromegaly. Acromegaly happens if epiphysis fused and growth hormone excess is present after epiphyseal fusion. So if there is no epiphyseal fusion, growth hormone will act on the epiphysis and it will lead to tall statured patient. And if there is epiphyseal fusion, then growth hormone can't increase the length of epiphysis or bone, so there will be no gigantism or tall stature, but that patient will have large mandible, big hands and fingers, large tongue, and sometimes there will be certain organomegalies. And both of these patients will have hyperglycemia because growth hormone increases the blood glucose level. And if there is decreased amount of growth hormone, then there will be dwarfism. Dwarfism can be due to various reasons. One of the reason is destruction of somatotrophs. This can be due to pressure effect of another pituitary adenoma, like lactotroph adenoma will lead to, like prolactinoma, which is nothing but lactotroph adenoma, lead to compression of somatotrophs, will lead to decreased production of growth hormone. Another cause is Laron dwarfism. Laron dwarfism is due to defect of growth hormone receptors. Here I have told you that growth hormone will act on hepatocyte via growth hormone receptor, and there will be increased IGF-1, 2 and somatomendins, which will lead to increased epiphyseal growth. So if there is growth hormone receptor defect, then growth hormone will be present but IGF will be low. So in case of Laron dwarfism, we have increased or normal growth hormone but decreased IGF level, IGF-1 or IGF-2 level. Another cause of dwarfism is Turner syndrome. And one of the cause of dwarfism is psychological dwarfism. Psychological cause. Here, if any child is a victim of abuse or neglect without any nutritional deficiency, there is no nutritional deficiency in psychological dwarfism. No nutritional deficiency. Then this patient will lead to, due to abuse and neglect, will lead to dwarfism. This is known as psychological dwarfism. And another fancy name for this is Kaspar-Hauser syndrome. This Kaspar-Hauser syndrome name came from the first patient of this type of dwarfism. And the last type of dwarfism is achondroplasia. Achondroplasia is due to defect of a epiphyseal growth factor receptor subtype 3. If this receptor is defective, then there will be less effect of epiphyseal growth factor, which will lead to decreased development or growth of epiphysis and lead to dwarfism. There are certain drugs which helps in treatment of dwarfism due to growth hormone deficiency or growth hormone releasing hormone deficiency or IGF-1 deficiency. Growth hormone releasing hormone deficiency will be treated via sarmorelin, masimorelin, tesamorelin. You can remember this name by ending morelin. Growth hormone analogues are somatrim, somatropin, and the latest drug is lomapacin. You can understand this name by soma or oma. And the last is IGF-1 analog. Here is two drugs. One is mecalsermin and another one is rinfabet. This drug will be useful in case of dwarfism. And there are certain drugs which helps in treatment of acromegaly. We can't do anything for gigantism because there is already gigantism present, so we can't make any tall patient shorter by medication. So we can treat acromegaly via certain drugs. They are certain somatostatin analog and growth hormone receptor blocker. What are the somatostatin analog? Somatostatin analog like octreotide. Octreotide has certain other uses also. This octreotide also increases the splanchnic vasoconstriction. Splanchnic blood vessels are nothing but blood vessels around our GI tracts. So if there is any splanchnic vasoconstriction, there will be decreased variceal bleeding. So this is very much useful in case of variceal bleeding in CLD patient. Another analog of somatostatins are lanreotide and pasireotide. These are somatostatin analogs. And growth hormone receptor blockers are there is only one. You just need to remember this name. pegvisomant. We can remember this name. This is pegylated drugs and somant, and so antagonist of somatotrop receptor which is